Hello, and welcome to OBGYN Made Easy. I'm a board certified OBGYN. I have a background experience in the United Kingdom
Magnificent.
before I moved to Texas, where I finished my residency. Hey y'all! And currently I'm practicing in California. If you're a student, a resident, or somebody who wants to know about OBGYN in a very simplified way, you've come to the right place. I believe in a very simple fact is that if learning is not fun, you won't memorize it at all. So let's have some fun and jump right into it.
Another high-yield topic, which is Polycystic Ovarian Syndrome, or PCOS for short. Let's start by defining the condition. Polycystic Ovarian Syndrome is defined as a hormonal disorder of unknown etiology causing enlargement of the ovaries, anovulation, hyperandrogenism, and insulin resistance. So how do we diagnose polycystic ovary? Well, most centers use the Rotterdam criteria for diagnosis. It has 3 components, and if patients meet 2 out of the 3, they qualify for the diagnosis. Those components are oligomenorrhea, hyperandrogenism, and ultrasound findings, and we will talk about those separately. Let's start with the ultrasound. PCOS is characterized by the presence of 12 or more follicles 2 to 9 millimeters in diameter, or if the ovary is enlarged to 10 cubic centimeter. When it comes to assessing for hyperandrogenism, we can use either biochemical testing or it could be a clinical diagnosis. For example, patient may complain of hirsutism, acne, and to a lesser extent androgenic alopecia. The last component of the Rotterdam criteria is oligomenorrhea, which is defined as infrequent menstrual periods of less than 6 to 8 periods per year. Women seek medical attention for a variety of reasons. One of them is infertility. Or they might present with symptoms of hyperandrogenism like hirsutism and acne. Women with PCOS often struggle to lose weight in spite of heavier exercise. Or simply they might present to the office because their menstrual periods are very hectic and they want to regulate their periods. Testing for PCOS can be divided into 3 categories. The first category is to confirm the diagnosis by testing either total testosterone with sex hormone binding globulin or by measuring free testosterone level. The second part is ruling out conditions that might present similar to PCOS, like thyroid issues, prolactinoma, congenital adrenal hyperplasia, and Cushing's syndrome. The third and the last part of testing for polycystic ovarian syndrome is assessing for complications like diabetes and high cholesterol. Treatment of polycystic ovarian syndrome always starts with lifestyle modifications, whether the patient complains of infertility, symptoms of hyperandrogenism, or oligomenorrhea. Then we individualize patients based on symptoms. For oligomenorrhea, we can prescribe the oral contraceptive pills. For infertility, we can use the ovulation medications clomiphene citrate and letrozole. We will talk about those medications in details in the infertility lecture. And as a second-line treatment, we can use ovarian drilling, which is a surgical procedure. There are a variety of medications to treat hirsutism. We usually start with oral contraceptive pills. We can add spironolactone, which is a diuretic. It has to be combined with a reliable method of contraception because it's a teratogenic drug. Less commonly used drugs are flutamide and finasteride due to side effects. And lastly, the drug eflornithine, which is an ornithine decarboxylase inhibitor, and we'll talk about those drugs at the end of the lecture. Don't forget to tell patients about waxing and other mechanical hair removal methods like laser treatment. Do not ignore treating associated conditions like diabetes and hypercholesterolemia, and the medications we use for those conditions are metformin and statins. You might have noticed that I did not mention metformin as treatment of infertility. That's because metformin is only used to regulate blood glucose in PCOS and should not be prescribed alone for that reason. However, metformin can induce weight loss, which in turn can induce ovulation. You also remember we talked about spironolactone for treatment of hirsutism. That's because it has an anti-androgenic effect. It's very important to remember that it is a teratogenic drug and a reliable method of contraception is important. Also make sure you check the renal function and the potassium level because it's a potassium sparing agent. Flutamide is another drug that we use for treatment of hirsutism. It binds to testosterone receptors, preventing the effect of testosterone. Again, a reliable method of contraception is required. The most common side effect includes dry skin and to a much lesser extent hepatitis. The issue with this drug is that it's only been involved in smaller trials for treatment of hirsutism. Finasteride is a drug commonly used in the treatment of enlarged prostate in male patients. It is a 5-alpha reductase inhibitor. It's also a teratogenic drug in male fetuses, and you know the drill with all the teratogenic drugs: give contraception. Eflornithine, commercially known as Vanica, is another drug that's used topically for treatment of hirsutism. It inhibits ornithine decarboxylase enzyme, which is important for hair growth. Side effect includes burning and erythema.
Don't forget to check out my books on Amazon. One of them is called OBGYN Made Easy, Don't Waste Time on the Shell, The Pearl is Inside, and the other one is for questions and answers. And the links are provided below. If you want to support this channel, please like and subscribe. If you have any question or any suggestions, please leave them in the comments below and I will do my best to address them. Guys, my commitment to you is to provide you with the latest information based on the most recent American College of Obstetrics and Gynecology guidelines. Thank you, and see you next time.